Hi friends, I am Dr. B.V. Rao of Rupture Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the kidney and ureter injuries. The common form of injuries are due to blow on the loin, blow from in front, accidental injuries. Hematuria following minor injury suggests that there is some pre-existing renal condition like stone hydronephrosis or tuberculosis. The degree of injury varies from a small subscapular hematoma to a complete tear involving the whole thickness of the kidney. The kidney may also be avulsed from its pedicle. The tear of the renal parenchyma follow the lines of uriniferous tubules. The whole of one pole may be detached. The injury is extraperitoneal except in children where there is a little perinephric fat. In these cases, the peritoneum related to the kidney is liable to be torn, in addition to the renal capsule, allowing blood and urine to escape into the peritoneal cavity. Clinical features: there is local pain and tenderness and rarely superficial bruising. Hematuria. Hematuria is the cardinal sign of damage to the kidney, but it may not make its appearance till some hours after the accident. If the hemorrhage is profuse, it may be followed by clot colic. Severe delayed hematuria. Sudden profuse hematuria can occur between the third day and third week of the accident in a patient who appeared to progressingly favorably. Meteorism. In majority of cases, renal injury abdominal distension comes on about 24 to 48 hours after the accident. In all cases, probability it is caused by a retroperitoneal hematoma implicating splanchnic nerves. A phrenic hematoma should be suspected if there is even a slight flattening of the normal contour of the loin. Management and treatment. Conservative treatment is usually successful and must be instituted at once. However, it must be remembered that injury to the other organs may be associated with injury to the kidney. The patient must resit flat in bed till the macroscopic hematuria has been absent for 1 week. Morphine should be given for pain and as a sedative. Hourly pulse and blood pressure chart must be kept. Sulfonamide or an antibiotic is given to prevent the infection of hematoma. Save a sample of each specimen of urine passed. Blood grouping and cross-matching is done as a transfusion may be necessary in case of shock or continuing hemorrhage. To know the condition of the other kidney, an urgent intravenous urogram (IVP) is obtained urgently. Under this regimen, the hematuria should be diminished, pain and guarding decrease, pulse and color of the patient improve. If there is signs of progressive blood loss, swelling in the loin, signs of perirenal infection, exploration is necessary to conserve the kidney or a part of it. If the facilities for the pyelography not available, the presence of a functioning kidney on the contralateral side can often be confirmed by chromocystoscopy in case of urgent operation arises. When the kidney is found to be ruptured in several places or the kidney pedicle is damaged, nephrectomy must be performed. Small tears can be sutured over oxycell or a piece of detached muscle promotes hemostasis. Larger single rents in the middle of the kidney or best are dealt with performing nephrostomy through the rent, and suturing the kidney. Partial nephrostomy may be helpful. When a sole existing kidney is damaged sufficiently to necessitate exploration, it must be repaired. If this step fails, the wound is packed firmly with a gauze with the hope that the bleeding is controlled and also that the ruptured kidney may heal. In all cases, the peritoneum must be opened to exclude damage to the organs. If there are signs of intraperitoneal hemorrhage or peritonitis, laparotomy must be performed. The lacerated kidney is repaired by transperitoneal route, is followed by careful closure of the posterior parietal peritoneum and drainage of the kidney through the loin. Antibiotic therapy is started. If there is a severe intraperitoneal rupture of the kidney, abdominal nephrectomy is performed. If the contralateral kidney is present, an easy matter to ascertain when the peritoneal cavity is open. Multiple injuries of kidney. When both organs, spleen and kidney, are injured, simultaneous splenectomy and nephrectomy are to be performed successfully. In case of rupture of kidney with damage to the liver or hollow organs, often complicated by fractured ribs, pelvis or vertebrae. Complications. Clot retention in the bladder is easy to manage and can be cleared with a plastic catheter and a gauze syringe. In course of about 2 weeks, pararenal pseudohydronephrosis may occur due to combination of a complete tear of renal cortex and ureteric obstruction. Hypertension may occur due to fibrosis of the kidney after 3 months or more. Nephrectomy is of help. Anuria of a renal artery. Aneurysm of a renal artery. It is rare and symptoms being the pain in the renal region, and if the aneurysm is large, a non-tender swelling will be felt. Rarely it is pulsatile and a bruit may be heard. An X-ray may show a shadow in relation to the pelvis of the kidney. An IVP may reveal that swelling is extrarenal with the renal pelvis displaced laterally. Aortography. Aortography will confirm the diagnosis. Attacks of hematuria occurs and which are probably due to congestion of the renal parenchyma. The aneurysm may rupture into the peritoneal cavity or into the peritoneal tissues. The result may be fatal. Treatment. Usually the nephrectomy and excision of the aneurysm are undertaken successfully. Rarely a saccular aneurysm may be resected with the preservation of the renal vessels and the kidney. Injuries to the ureter. Rupture of a ureter. Rupture of an ureter can occur as a result of an accident involving hyperextension of the spine. The quantity of urine is diminished and is the first symptom. There may be swelling of loin or iliac fossa. An IVP reveals a diffuse shadow below the kidney in the injured side. Injury of one or both ureters during a pelvic operation. It is more common and occurs during the course of a difficult hysterectomy. Preliminary catheterization of the ureters prevents such accidents, as catheters within ureters can be seen and felt and prevents mistakes. The accidents include division of the ureter, ligature, crushing it with forceps or removing a portion of its wall. Injury recognized at the time of operation. The relation to the ureter and the bladder is restored unless the patient's condition is poor and ligation of the proximal end of the ureter is the best course. If the patient realizes within 2 days, temporary nephrostomy is carried out and a repair operation is undertaken later. Injury not recognized at the time of operation. Unilateral injury. Three possibilities are there. No symptoms. If one ureter is ligated with unabsorbable sutures and the opposite kidney and the ureter are normal, in a majority of cases the kidney on the obstructed side undergoes silent atrophy. Thus the accident is silent unless the patient sometimes later undergo urological examination. Lumbar pain. In few cases, hydronephrosis and pyonephrosis may occur. Excretory pylography reveals no excretion on the side of the lesion. Nephrostomy should be undertaken early to avoid infection of developing hydronephrosis. A repair operation can be undertaken later. Urinary fistula through the abdominal incision. Following and pan-hysterectomy through vagina or through the abdominal incision, a fistula may be developed. A temporary nephrostomy may be performed and a repair operation postponed till edema and infection have abated after an interval of about 6 weeks. Bilateral injury. An attempt is made to pass ureteric catheters in case of anuria following ligation of both ureters during hysterectomy, and both ureters are occluded. The wound should be explored and ligatures removed. A repair of the injured ureter. In case the ends of the ureter are clean cut and length is not lost, each end should be split for 1.5 cm and the edges united as a flat ribbon. A soft latex T-tube is left across the gap for 2 weeks. This is to be preferred to end-to-end suture, which usually results in stricture ureter formation. In division low down, it may be possible to re-implant the ureter into the bladder. Boari'soperatio. To replace the lower ureter, a flap of the bladder is turned up. Rarely, where the conservation of all the renal tissue is vital, replacement by a segment of ileum is necessary. Nephrectomy is the best option in the elderly patient with a malignant condition. That's all about the injuries of the kidney and ureter, and in the next video I will discuss about some other disease. Thank you.